This is a patient with history of elevated PSA. This was the original study that was done. And here it is. And then here's a diffusion. ADC. What do you think?
Okay, so I'm concerned about that
Not really
anterior.
an yes. This,
Yep.
right? And yes, and that was a PIRADS 5. Patient got a biopsy and it was negative. And so patient got a repeat MR a couple years, like a year later. Let's see, is that right? A year? Yes, 2 years later, and a repeat MR. And I'll tell you that the imaging study looked very similar. Okay, that was the first one. Oh, here it is. Sorry, the patient got a study a year later, and there's your anterior lesion. Size is similar, but there's a restricted diffusion, and I got a second biopsy, and that was also negative. And then got
And what's the
another
PSA doing right
MR.
now?
PSA is increasing a little bit. Yeah, so it was 5 and then it went to 7. Okay, got a biopsy again after the second MR and it was still negative. And then got a third MR. So we still see the same thing. And this time it was positive. The third biopsy, it was transperineal. The first two were transrectal.
And were the first two fusion? They must have
Yes.
been. Yeah.
Yes.
But
They were
I guess
fusion.
like is this the pitfall of like it's so anterior that like it's maybe just hard to get there unless you go perineal?
Yes. Yes. That's exactly right. So this is the lesion here. It's very up high, anterior, right? And these are commonly the lesions that are missed by transrectal because it's so anterior, right? You can just imagine like if the needle's here, it has to go pretty deep and far, right? And with the transrectal, there's a lot of distortion with the co-registration and stuff like that. So, more importantly, I think it's primarily the location, right? It's really deep and it's very high. So the patient had a transperineal the third time, and then we got grade group 2 or 3. So I think it was like 3 plus 4, 4 plus 3, prostate cancer.
In transperineal, it still has to go pretty far, but maybe less distortion.
Yes, it's also fusion, and I think there's less distortion. The literature suggests increased diagnostic yield compared to transrectal, and more importantly, there's decreased risk of sepsis, urosepsis, complications from biopsy.
Interesting.
Yeah. Can you pause for a sec?
Yep.
So the patient got a PSMA MR, and that lesion is here over there anterior, and also the patient had a focal uptake in the thoracic spine here. So that there's a couple of teaching points with this case. The first one that I want to bring up is this one: imaging. How do we interpret kind of unifocal PSMA positive? Well, the first teaching point is, if I think there's, and I think we're going to it now with the new ACR designated center for prostate center excellence, the importance of reviewing radiology pathology modeled after what we do now for breast. And that's going to be really important for these cases where we get discordant pathology, and reviewing these cases can really improve our learning. And number two, improve how we care for patients with prostate cancer. The second teaching point is this PROMIS guideline for interpreting bone metastasis or bone lesions. So if patients now with PSMA being so sensitive will commonly see, bone and lymph node mets that we would never like call prospectively by MR or CT. And this is the proposed workflow for interpreting them. So And this can be a challenge sometimes when you just have one lesion and the patient has, for example, low risk intermediate disease, and where the risk of metastasis is low. So in these cases, let's just look at the bone because we have the bone finding here. So the first thing that we need to do is look at the CT or MR, right? Conventional imaging, and does it look suspicious? This was a PET MR, so we don't actually have all the sequences that we typically would do for spine. And we don't have any CT. So we can't really say if the imaging features look suspicious because of the limited nature of the PET MR that was done. So if it was suspicious, then we look at the MIPSMA score. So the MIPSMA score for this lesion was 2. And so if it's 2, so if it's 1 or higher, then it becomes positive, right? This is for suspicious. And then if there's no lesion on imaging, this was seen on MR, but you just couldn't characterize it because we got limited sequences on the PET MR. But if there's no lesion and it's only PSMA avid, then it follows a different workflow. So this is a great way to kind of interpret a bone, PSMA uptake on bone, and correlating it to conventional CT-MR.
That's super helpful, especially about the bone stuff because it gets really tricky.
Yes, and the third teaching point here is we got a PET MR. And the question is, well, when is a PET MRI indicated over just standard PET CT for PSMA? And I think unequivocally, if you're evaluating recurrent disease or you're needing to stage it like locally, then MR has tremendous value. If it's just screening, there's no role for MR. Yeah, so PET MR can be very helpful in the setting of recurrent disease, which is not this case, but if that would be one of the kind of key indications for PET MR over PET CT.
Cool. And sorry, the MIPSMA score, how do you get that?
It's out of 3, 0, 1, 2, 3,
Yeah.
and the nukes they interpret it against. It's just like Luval, what is it? Uh, Lugano-Duval score for lymphoma,
Yep.
where it's compared against certain standard like blood pool. So PSMA, MIPSMA, so 0 is less than blood pool, 1 is equal to or above blood pool but lower than liver, 2 is above liver but lower than parotid. Remember, parotid gland takes up PSMA. 3, and this is why actually parotid gland and lacrimal glands take up PSMA, and this is why they get dry mouth and dry eyes after they get treated with lutetium 177. Oh,
Oh,
anyways,
cool.
MIPSMA 3 is above parotid gland. So this was 2, which means it's
Pretty avid.
above liver but lower than parotid.
Wow. Very cool. Okay. Okay. So my case. Tell me if you see anything.
The right, like hepatic flexure,
Yep.
there's something happening there. There's a mass, and there's tumor infiltration and like maybe a perforation into the fat.
Excellent, excellent. So that's exactly what we were thinking. This looks like thickened, enhancing wall,
I guess it
apple
could be
core.
lymphoma. I mean, we don't know if it's adeno, but certainly needs a colonoscopy at some point.
Yeah, exactly. And I guess the clinicians were like telling us like, oh, this is really strange presentation for a cancer. Like they just had sudden pain. They have this rupture here. Are you sure it's cancer? Or like, could this just be colitis with like an abscess? And we said, we think this is cancer. It looks very thick. It doesn't look like edematous. It looks very thick and apple core-ish. It's 8 centimeters in length. But we do think that it's perforated. And then the question was like, do you think that we should stick a drain in this since this looks like a very inflamed thing and they wanted to cool the patient down? And so I don't think there's a correct answer here as far as like, if you think there's a tumor and it's perforated, but it looks like an abscess, is it okay to stick a drain in it? What we ended up doing was actually just sticking a needle in it and aspirating. And the cytology came back negative. It grew out some bugs and like it did really help this process to aspirate it. I do have a follow-up. Let's see, is this the one? Oh no, that's where it looks kind of similar. And then here you can see that the mass is still there, but the abscess is kind of basically gone.
And the
There is kind
track,
of,
there's thickening on that track. Hopefully that's just nothing.
yeah, it turned out to be nothing. All the margins were negative, but yeah, I think it's just like that's the resolving phlegmon. But anyway, they resected this and this came back adenosquamous carcinoma. So, stick to your guns about if it looks like an apple core lesion, even if there's a perforation or abscess affiliated with it, these tumors can perforate. They can spread into the pericolonic fat. And this was a cancer that had perforated. And it's really tricky in the setting of perforation, like because they don't want to go in and resect right at that moment because there's all this inflammation and stuff. So
This is a patient who had a abdominal ultrasound and there was like a splenic cystic lesion, and a patient got a CT, and this is what the splenic cystic lesion looks like.
I would have thought that could be like some kind of post-traumatic thing. Um, That's likely something like a kind of cockle or, post-infectious.
Yes, great, excellent, excellent. And so the echinococcus was also raised in the differential consideration. So the patient had that resected. This is a post-resection, and the pathology showed epithelial cysts. Epithelial cysts.
Huh. It looks
Um,
complex for an epithelial cyst, but I guess I don't know that much about the splenic epithelial cyst.
yes. So this multiple pathologists reviewed this case because again we had raised parasitic infection as a possibility, and they said that I'm seeing multiple epidermoid cysts. The cause, actually, I'm sorry, it was epidermoid cysts. These multiple epidermoid cysts, the cause is usually unknown, and it can be either congenital or acquired. So, an imaging finding of epidermoid cysts. But another pathologist said, well, these can also be splenic epithelial cyst or traumatic pseudocyst based on the path specimen. So, all of the above. For me, the take-home message was, if I don't these, it has a very benign appearance to me, the peripheral calcifications, and prospectively, I, I don't know if I would. I don't know. This patient got it resected, but when I look at this, I would probably downplay it so that I wouldn't, kind of force them into like a surgical treatment. But I don't know.
It's interesting
My
too that
call.
they did like a partial splenectomy because often you see like just like, okay, let's just take out the whole spleen.
Yeah.
I'm just looking up epidermoid splenic cysts are an example of primary congenital cysts that contain an epithelial lining, unlike secondary cysts that are composed of fibrous tissues. So it sounds kind of like I don't know, epidermoid and epithelial are similar, and they're both like sort of congenital and not like these secondary traumatic kind of cysts. But it just shows you too, like even on pathology, they weren't like completely certain at the end.
Yes. Yes. And maybe they've been there for so long and that's what led to the peripheral calcifications.
Yep.
Like it was congenital, I mean.
Okay, so this patient was having pain and swelling after intercourse. And we have
Oh
this
wow.
penile
What is
MRI.
going on with the spongiosum?
So the money kind of pictures here.
And then left, yep. And there's like a rupture or something posterior
Right,
and left
right. So what is this
um
called?
like a penile rupture?
It's called a penile fracture. Even though there's no bone, it's still
Oh,
called a fracture.
we're
And
calling
you said
eggplant
spongiosum.
penis. No, sorry, I saw this T2 hyperintensity around the cavernous and spongiosum posteriorly, but maybe that's just the normal
Yep.
right there.
Okay, exactly.
Like that, yeah.
So just a review of the anatomy. These are the corpus cavernosum. that are all blood filled. And then this is the
Yeah.
spongiosum where the urethra travels. So it's like the two eyes and the nose. And this is this dark band here is the tunica albuginea. There's one around the cavernosa, and there's a separate one around the spongiosum. And then around both of them is Buck's fascia. And then here we can see that there's this clear disruption of that T2 dark signal. So the tunica albuginea surrounding that cavernosa ruptured, and we've got this penile fracture here with extrusion of the cavernosal contents. And we also probably have a disruption of Buck's fascia as well. And the reason I bring that up is that there is a scoring system actually for penile fractures. I'm just going to pull up this, bring over this Radiopedia article, but so here it is, penile fracture grading. And basically, what was most helpful, I thought, was these images. So if you just have a little hematoma here, your tunica albuginea is intact. So that's just a grade 0, where you just have a hematoma from trauma. Grade 1 is where you have the tunica albuginea fractured. Grade 2 is where you have an intracavernosal hematoma. And then grade 3 is where you have a rupture of both the tunica albuginea and going into the corpus spongiosum, which I don't think we have in this case. And grade 4 is actually where you have urethral injury as well, which would make it a much more serious injury. But I think that we basically have tunica albuginea and Buck's fascia, but not really the corpus spongiosum. So I think it's like involving both of these guys, but not the spongiosum. So somewhere between a grade 2 to a 3. And this Radiopedia article does say that nobody really uses this staging system, but it basically just like will guide you to what you should be describing and what key structures that, is important for the urologist.
Can you show the spongiosum again? It was just so T2 hyper intense. Like what does it look like that? Like all the way through?
Let me
Like
see.
upstream and downstream of the fracture?
I think this, and to me, the spongiosum is usually really T2 bright. This coronal is not as helpful, but actually this
Yeah,
is really beautiful to show the defect, right?
it's really pretty, yeah. And
Um,
then they just surgically repair that
yeah, so they want to
to
know
preserve
where it is
potency.
exactly and how long it is, and then they go in and then surgically like sew this back up actually.
And what
But
was the reason for MR instead of ultrasound? I mean, typically I think these were diagnosed on ultrasound.
that is a great question. I don't know in this particular case. We have debated this in the past, and usually we do ultrasound.
Yeah.
But for some reason, this one went to MR. So I don't know if they did like a bedside ultrasound, and we're still not sure. But this one went to an MR.
And clinically they have very purple looking penis, they call.
Yeah. But I actually had another case where I thought it was going to be a penile fracture. It was the same kind of history,
Yeah.
but actually the history was like a cord-like swelling on the dorsal aspect of the penis, and it was actually a
Oh.
thrombosis of the vein.
Oh.
The Mondor's disease of the penis. So there are other things, and we could easily see it on ultrasound. I've shown it in this case conference where there was like a thrombosed non-vascular cord-like vein on the dorsal side. We of course had to like consult our, the internet, like remind ourselves like which veins are these and what's the anatomy here. But like the tunica was completely intact, and there was this like we could not see the dorsal vein. So yep, just
It's a
a
great case.
example of a penile fracture.
So
Yep.
you can. This is a patient who presented with these peritoneal findings. So there's
Multiple like necrotic masses.
yes, 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 and there's one here. This is probably the biggest one. There's one here along the abdominal wall. That's a man.
So I'm looking for a primary. When I see the
It
abdominal
was
wall
negative,
one
or like sorry, there, we couldn't find the primary
on the in the abdomen or pelvis.
in the abdomen and pelvis.
Yeah. Okay. So other things I'm thinking like melanoma. It looks a little too necrotic to be lymphoma. But then any kind of like primary like lung, squamous cell of the neck, any kind of aggressive primary tumor.
Yes, yeah. So the patient actually got follow up. I'm sorry, I omitted an important history, which was that the patient had history of renal cell carcinoma and had a nephrectomy. So Mets was raised, uh, and this went to biopsy, and the biopsy came back as myofibroblastic reaction with no malignancy.
Interesting. So sort of
And
like an
post,
inflammatory pseudotumor.
yes, and this is there's no treatment or anything like that. The patient got followed up, and then it was getting better and getting
Hmm.
smaller.
Wait, and were they on immunotherapy by chance?
The patient was on, yes, or actually leventinib. Is that immunotherapy?
Sounds like it. Inib. Let's see.
Yeah, it's Lenvatinib and everolimus. Everolimus is an mTOR inhibitor. Let me Google the other one. Lenvatinib.
It's a tyrosine kinase inhibitor with
Okay.
anti-angiogenic properties.
Okay, so no immunotherapy. It was a
Hmm.
TKI.
Very interesting. Huh. Well, good for them. We actually recently had a case very similar. Like there was a big liver mass and then it just spontaneously regressed and all the biopsies showed basically inflammation and
Oh wow.
myofibroblasts. And we're like, what? This looks like a cholangiocarcinoma and it's just a pseudotumor. So okay, so this is the case, and you can see that there is something external to the patient. So we've got our bladder, we've got our rectum, and then where, you should normally see your vagina and uterus, the uterus is actually inverted, completely inverted, and there's a mass that seems to be contiguous with the endometrium here. So we were pretty convinced that this was an endometrial mass that was so big that it basically like prolapsed and pulled out the uterus with it.
Was it an acute presentation?
Yes, it was.
Okay.
Yeah. So here it is. It acutely prolapsed. I don't think this helps, but anyway, this is that's the axial high res. So anyway, we were like, this looks aggressive and kind of, but it's not really invading anything. We don't know what it is, but it's coming from the endometrium. This was resected, and the way they resected it was actually first they did IR angioembolization of the uterus, so that they decreased the vascularity of this mass. And then they resected sort of like and block, like they resected sort of this part and then flipped the uterus back in to do a hysterectomy because they felt like they were, you can't really do a hysterectomy from the outside. And it came back carcinosarcoma. So I don't know if you
Wow.
remember, but last week I also showed a carcinosarcoma and I gave some teaching points about it. But basically, it is an endometrial mass, an endometrial tumor that is mostly a carcinoma, but it has some sarcomatoid features to it. It's pretty aggressive. It has a worse prognosis. It's not a sarcoma like a leiomyosarcoma. It doesn't arise from the myometrium. It actually rises from the endometrium, and it's pretty aggressive. So this is just a very different presentation of an endometrial carcinosarcoma.
Wow.
Yep.
I'm surprised by how big it is. I mean, I'm surprised the patient wasn't symptomatic prior to the prolapse. Or
Yeah,
maybe
well,
they
when things
were.
are
I don't
deep in
know.
your abdomen, it's sometimes harder to, feel them. I'll show you the path
How
specimen.
old was the patient?
Um,
Because endometrial
60,
car. Oh, go ahead.
60s.
Uh, endometrial carcinosarcoma are usually symptomatic. Like they'll get vaginal
Bleeding.
bleeding.
Mm-hmm.
Yeah,
Yeah.
because of it's an endometrium, and these are diagnosed typically, yeah, hysteroscopically.
Yeah. I don't know the story, but this was the final path specimen. So basically this was this was post embolization. So a lot of the tumor was like devascularized. So okay, this was an interesting case shared by my fellow Nate. You can see basically they're talking about the ureters here. So if you follow, for example, this ureter here, it's actually going into this inguinal canal.
Oh, cute. Yeah.
And there's these big bilateral inguinal hernias. There's some fat necrosis on this side. But
That's a
They-
really long ureter.
yeah. And then this ureter too, and there's like mild fullness bilaterally. And then this ureter also, if you follow it here, goes out into the hernia. So this is what is called a uretero-inguinal hernia. And it's just a very rare thing, but it's really important if you do see it to point it out, because as you can imagine, if they just went to go repair this hernia, they would just completely lacerate across these ureters. And you'd have to like eventually have like reimplantation, and they might be too short and all that stuff. So when you have this situation, they usually put stents in. They try to put stents in. So the ureters in this case, they go in and then they come back out of the hernia and then insert in the bladder. So you could put stents in to try to just like see the course of it. And then when they're doing the hernia repair, make sure that they like palpate the stent and like preserve the ureter.
That's a great pickup because the ureters, I mean, even though they're minimally thickened, they're not dilated or there's no other findings
Yeah, they're not like
of
too dilated, but yeah,
obstruction.
they were just
Yeah.
like, wait a second, they're going out to these hernias. So
Oh, that's
great.
amazing.
Okay, that's it.
Awesome. Thank you so much, Aarti. I will see you next week.
Okay, bye.